normally have about 190 plus intensive care units in Australia, with over 2,000 intensive care beds. And we did some predictions which thought that the increase in those numbers that might be needed for a maximum surge of cases would be about 200 to 300% increase. And it was felt that that could be largely coped with by sourcing ventilators from veterinary surgeons and various places, as well as ordering from domestic manufacturers and overseas. And in particular, the staff requirements, many current nurses working in non-ICU positions were upskillable to deal with ICU patients. And then recruitment processes went out to get non-working nurses, of which there are quite a few, both in early and late retirement, to come back and fill those spots. And we had the time to actually process that. We also had time for training and use of PPE. And in those 2 weeks, again, of total lockdown, there was really a complete cessation of routine operating lists. And during that time, we performed only Category 1 emergencies. And it allowed all the theatre staff, as well as hospital staff, to be trained with the PPE and to look at workflow and to catch our breath and see what was going to happen. As many wards as possible were altered to be able to deal with non-ICU respiratory patients. Any patients on the ward who didn't need to be there for other cases were discharged, and we worked out action plans to deal with staff sicknesses, etc. We allocated specific theatres to be used for COVID patients. And we moved all of our outpatients, as I think everywhere in Australia did, to a primarily telehealth or over the phone facility, something that we do have an already pre-existing ability because of the geographical size of Australia. We already perform many telehealth clinics, and it was quite easy to do some of those changes. In our vascular unit specifically, we have a number of consultants and registrars, and due to the fact that we were reducing our workload, we were able to split teams into 2 or 3 separate groups, so that if ever one group were to get infected and need to self-isolate, another group would be able to continue working. We obviously tried to socially distance. We did have some trouble because we have a hybrid vascular suite, as many people and many units do, and many of the things in the suite are quite awkward to clean, but we were lucky enough to have a second hybrid used by cardiologists, and we were able to utilize their theatre as an emergency to use for positive cases and continue to use ours for routine uninfected cases. And we made some policy changes, although luckily we never really had to activate on these, but they were that we would no longer operate on aneurysms unless they were larger than normal. We would only operate on symptomatic carotids. We would consider allowing high-risk ruptured aneurysm patients to die rather than to try and repair them. And we'd do simpler surgeries such as amputating legs rather than try complex reconstruction, etc. The other interesting thing is that in Australia, we have both public and private hospitals that tend to operate in quite a separate way. But during this period, there was an unprecedented unprecedented collaboration really between the public and private, such the government was able to gain access to the private facilities when needed. Also, the private hospitals reduced their activity and still are on a reduced activity at the moment. So there was quite a lot of anxiety, as I suspect there is everywhere. One of the things we're most concerned about was personal protection equipment. And similarly, again, to Dr. Wang, who said, I think she had only a week of equipment available at the start. I think our stocks were the same. There was a lot of anxiety about whether or not we were being given the right advice about PPE, and some of that comes from seeing excellent pictures from China and Italy and so on of the PPE there, and then comparing it to what we were being advised was correct PPE. But it's very interesting to know that although our numbers in Australia have been very small, the transmission to working staff members has, I believe, been almost zero.